So back to our case, he goes on, he has a PSA of 25 at the beginning, he goes on ADT, gets chemotherapy. At the end of 6 cycles, the PSA is down quite a bit. It's not normalized, but it's 6.2. 2 years after that, he's followed and presumably does quite well because we don't hear anything from him. But 2 years after that, he comes back. His PSA is rising, and he's on ADT at this time. PSA is 10.8, and he's followed for a bit. And he does ultimately develop worsening symptoms and a rising PSA to 21.4 with a relatively rapid PSA doubling time of about 5.1 months. And he has no new bone lesions that are shown on imaging. So while this sounds very straightforward, there's a lot of nuance actually in what's going on with this case. Should we have followed this patient when he presented with a PSA of 10.8? Should we have started abiraterone on him at that time? Is it appropriate to wait for a patient to develop symptoms before we initiate a new treatment? These are all reasonable questions. However, the use of abiraterone in the CRPC setting in an asymptomatic patient is well justified for now 10 years or so, based on the Cougar 302 study that led to the approval of abiraterone in that setting. Enzalutamide similarly was demonstrated to have very similar benefits in this setting. So it would have been very reasonable to initiate abiraterone at the PSA of 10.8. It is a little bit dismaying that by waiting 5 months, the patient went from being asymptomatic to symptomatic, but that does happen, of course. And in conversation with patients, many patients choose to wait. They don't want to be burdened with further therapies. They're afraid of the monitoring. They don't want side effects. They don't want the added cost, et cetera, et cetera. So that ultimately is a conversation that takes place between you and your patient about when to consider further therapy. Suffice to say, this patient then starts on abiraterone at the standard dose of 1,000 milligrams a day with prednisone 5 milligrams twice daily. That is the standard treatment for CRPC. Now, the truth is we have relatively little data and no real phase 3 data on the efficacy of abiraterone in the setting of CRPC in which the patient received docetaxel for CSPC, because it remains something of a new clinical state. But I think we can still have reasonable expectations for success of this therapy. And when I counsel a patient about the use of abiraterone in this setting, I'll typically offer him an estimate of about a 75% likelihood that his PSA will go down by 50% or greater, and that he'll be able to be on this treatment for anywhere from 1.5 to 2 years based on the depth of that PSA response. However, in this case, he fits into the 25 or 30% or so who may have had an initial reduction in abiraterone, but the PSA continues to rise. So he gets a less than average benefit from abiraterone in this setting. PSA ultimately 30.2, and an abdominal pelvic CT scan shows multiple new liver lesions, one new vertebral lesion, and one new appendicular lesion along the spine or the sternum. So this again brings up a little bit of nuance. Recall that when we went back, when his PSA began to rise after the docetaxel, we did a bone scan and saw no new lesions on imaging. It's very typical that a patient will develop a worsening of disease with a rising PSA, but no new bone lesions. And that's what we saw in the beginning. But now when we see this patient developing new bony lesions, that meets sort of our standard academic criteria for radiographic progression. And it also puts him in a position where he is experiencing perhaps more rapid disease progression. And most notably, he's developed now liver metastases, which put him in a fairly adverse prognostic category. So even though his PSA is not that high, it's only 30, we're seeing a lot of new lesions develop. And this does bring up some other concerns that are emerging in the field. Should we biopsy one of these liver lesions? While there is very little likelihood that this is not prostate cancer, I believe that over time, we're going to develop a more nuanced understanding of the various histological forms of prostate cancer that can evolve under the treatment pressure of drugs like abiraterone or enzalutamide or even chemotherapy. We now know that maybe 20 to 30% of patients in this setting will harbor a neuroendocrine type disease or neuroendocrine prostate cancer, which you'll sometimes see abbreviated as NEPC. This is different from small cell prostate cancer, which is a very rare disease, which is present in maybe only 1% of prostate cancer patients, and is generally not associated with hormonal responsiveness, and mimics really the same type of clinical issues you see when you confront a small cell cancer in the lung, for example, simply that, but that this is evolving in the prostate. So neuroendocrine prostate cancer could be something that is developing here. We also know through recent publications, for example, that patients developing rapidly progressive disease in the context of what one would call a relatively low PSA is associated with worse prognosis. And there have been some recent publications demonstrating that, showing data on that point, which is something we've sort of assumed all along.